Dr. Tom Perry joining us from Therapeutics Initiatives down south, and he'll be doing most of the didactic speaking and sharing some videos tonight. And thank you for coming. We're hoping that this will be quite engaging, so feel free to turn on your video, take off your mic, and hopefully have some discussion as we go through tonight. Next slide, please.
Okay, let's...
Yes, so as I mentioned, we're going to be discussing chronic pain medications today, and we can go to the next slide. Neither Tom nor I have any disclosures today. Next slide, please. And our learning objectives are there for your reference, and they're also included in the invitation email for tonight's webinar, so you can take a look there for any more details. But we wanted to start out with a case tonight. So it was a patient that I worked with here in Dawson Creek. She's a 22-year-old female with chronic leg pain after a motor vehicle accident in March 2020. She explains her pain as a severe weight or pressure that's essentially on her kneecap, but radiates both up and down and is quite excruciating and making it difficult for her to mobilize. She's had 2 operations since her motor vehicle accident last year, awaiting a third for a rotational deformity of her right femur that was just confirmed by CT earlier this month. And one of her main concerns is restlessness that she's been describing that's been quite troublesome to her. And she was referred to me to determine if this may be medication related. Next slide, please.
Oh, let's see now. Oh, I'm sorry. I think I figured out.
That's okay. So seeing this list, even as a pharmacist, it was quite overwhelming to me to try and figure out what these medications were indicated for and dosing and things like that. So her medication history, or medical history, sorry, was depression, anxiety, chronic pain from this accident, and the restlessness that she's describing, as well as insomnia, nausea, and pantoprazole, which I'm presuming was for gastroprotection being on an NSAID. Not sure other than that, and that should be 40 milligrams twice a day. For her medication list, she's on Lamotrigine 150 at bedtime. This was started prior to the accident, and there is some query that she has bipolar disorder rather than the depression anxiety, but it's still undetermined. She's on gabapentin 600 milligrams at bedtime, prescribed as twice a day, but she preferred to only take it at nighttime. Tramadol 1 to 2 tablets twice a day, ketorolac 10 milligrams daily that was prescribed after her most recent surgery in March of this year that she just recently ran out of. Lorazepam 0.5 to 1 milligram daily as needed, which she's only used a handful of times as she found it wasn't effective. Benztropine 0.5 milligram twice a day, as well as Duloxetine, which is a new addition due to the ongoing chronic pain. Duloxetine, again for the insomnia, ondansetron and buscopan for her nausea, as well as the pantoprazole. So leaving it at this, I was hoping that we could have somebody speak up and give their thoughts on this regimen of medications, any thoughts as to what may be causing this restlessness, and any ideas on how you would approach this patient with chronic pain.
We're not going to let them get off the hook, are we, Sydney? We're
not at all.
We're not going to show anything else.
How is her? Is she like even able to, function cognitively during the day? It looks like she'd be in a state of almost total. I get like not stoned, but tired with everything on there, right? So what's?
No, she was quite fatigued. I mean, I only spoke with her over the phone because of COVID concerns, but
right.
She is just so tired, mostly from the chronic pain and how that affects her life. But
absolutely,
other than this restlessness, didn't have many concerns other than from the medications, other than she didn't really feel they were helping.
Well, with all of that, if she doesn't feel they're helping, it probably isn't helping, right?
Exactly. So I guess our next little bit to tease out is what would we adjust first and how would we do it?
You could start with it. I think Christy is right. You could start anywhere. There's just such a cocktail here, and it's really hard to know where to begin. I mean, I always look at the PPI, but that's a separate issue entirely, and that's not what's making her drowsy and maybe a bit confused and restless. But goodness, this is, what I'm sensing here is like just, and maybe she comes across as frustrating and irritates the doctors or whatever, and people are desperate, and so now she gets added on Duloxetine because maybe it's got a role in chronic pain, and it's just like a desperate move by a physician. Here's your prescription, rather than addressing the polypharmacy and what's really going on here. So just that Duloxetine is like the icing on the cake. It's the last straw, as it were. But she's still got a problem no matter what. So you could jump in, and I mean, gabapentin would be one way to start. The talk that Rochelle gave us a few months ago indicated that truly, you know, maybe if it works, it's wonderful, but it works effectively in about 1 in 8 cases. So the trouble here is how do you even know if it's working or not? Because she's on so many things. It's very difficult to tease this out. And my own feeling is you got to start somewhere, but you could start virtually anywhere here.
Absolutely. Are there any particular medications of concerns or combinations that come to mind when you're thinking about this restlessness that she's describing?
Well, you know, this is just anecdotal, talking to a lot of people who like treat sports injuries and things. I have no clinical evidence to support this. Maybe Tom can jump in here, but I find that people who use a lot of anti-inflammatories like NSAIDs, after a long time, they explain a form of restlessness or like skin hurting and things such as that, or that they're the pain isn't changed, but they almost feel like some of the inflammation in their area they're treating feels a little better, but then their other joints begin to hurt. Now, is that something like the salt, or like, does that affect the electrolytes in a way? Or, and it seems to be like, I'd like to start looking into it because I've started hearing it a lot lately. And have you heard anything like that, Tom? People who overuse
I haven't. I wouldn't dismiss it. Are you saying you hear this from?
My circle of us geriatric beat up sore martial artists and baseball players, and right, or people who have had chronic pain for a while and, you know, have never, you know, are proud of themselves because they've never used an opioid or something like that, but their Advil, you know, they use it, or their ibuprofen or their Aleve, they use it, but they say that when they don't use it, they don't feel any different either, except for they don't have like skin pain or stretchy, you know. And I'm like, this is like, I've heard this about over the course of a year or so, 6 or 7 times. And I actually did want to connect with you at some point to wonder, is it something you come across?
Why did they use it then?
Because they have pain, right? They have had a hip injury or a shoulder injury, or, you know, it's an anti-inflammatory, so they're in pain. I tell them, you know, well, what happens if you don't stop? Or what happens when you stop? And they say, well, then my hands don't feel bad anymore, but my hip still hurts. I was like, okay, well, when you use it, does your hip hurt? Well, yeah, but then my hand's starting to hurt and I feel like I'm retaining tons of fluid. It's like, well, how about you stop using them? So I've had a few people just stop their NSAIDs and they're like, my skin feels better, but my pain is the same. So, and then that's exhausting.
I think that's genuine, Rochelle. Just even the slight fluid retention, and just a lot of people describe, I don't think it's an allergy, but there's just this sort of discomfort, unease in the skin. And some people might use the word restlessness for that. I mean, I look at this medication list and, as we said, where to start, but I'm never happy seeing a person on long-term ketorolac. I mean, if it's being used on an acute basis for a few days for severe pain, that's one thing, but this looks like it's long-term. And the other thing that I'm seeing,
definitely a red flag.
Yeah, and the other thing I'm seeing is that people probably feel good that she's not on an opioid, but she is on Tramadol. So I can see the physician justification here. Well, we've got her on all these things, but she isn't on anything serious and major opioid-wise, so we're okay.
Yeah. And the other thing we have to consider is, yes, this referral came from the GP, but she also has psychiatry involved. She has a surgeon involved. There are so many different people that are prescribing things that others may not know. Mm-hmm. So that's where that importance of a proper medication review really comes in, to find out what a patient's truly taking.
So, and is her nausea and vomiting, I'm sorry if you had mentioned it, is it condition related or is it because of this, the meal of tablets she takes?
Exactly. Great question. And I don't know that we know the true answer to that.
Okay.
It would be nice to know what was her pre-accident function level and how was she feeling before it. What kind of trauma left the accident? Like, how did she put it in her framework of life? How is she still traumatized from the event? And then to look what other modalities were used. Did she attend physio? What is her function level? Did she try maybe acupuncture, physio, other modalities? But
And
this is quite the list to end up on. It's quite scary.
Right. So my thought process going through this was I knew that this restlessness was a huge concern for her. It was quite new since starting all of these medications. She didn't have it prior to the accident. And being so bothersome, that's what I wanted to target first. And then we could work on the pain after that. So going through this list, first thing I looked at was the Lamotrigine. It does have an akathisia risk, but the patient was taking it prior to the accident. So it's pretty unlikely that that's the cause. It could be part of the culprit, but unlikely my first step, especially if this query bipolar disorder or depression was quite controlled otherwise right now. The gabapentin was another one that came to mind. The patient really denied benefit from this, so I thought, great, this would be a great place to start. And knowing that a risk in pediatric patients is that they can be quite agitated, have emotional liability, hostility, and hyperkinetic muscle activity. Although it's a pediatric population, I've actually seen it in a couple of younger women as well that have this type of restlessness description that goes away as soon as they stop it. So again, that's something that came to mind. We could try that. I also thought about the Duloxetine and Tramadol combination because we know Tramadol not only is an opioid, but has SNRI effects. So we're essentially mixing Duloxetine with an unknown dose of SNRI from Tramadol because we don't know how a patient particularly metabolizes this and how much opioid they're getting versus how much essentially venlafaxine or duloxetine they're getting. Another thought here was like a serotonin syndrome. This also kind of encompasses that patient's nausea. Is that maybe what's going on here? And something that we could try there is switching opioids to something that her body doesn't necessarily have to metabolize to be effective. So we could look at something like morphine in the short term to get her through to her next surgery to see if we could get some benefit there. Again, the loxapine has the EPS risk. It's not being helped by, her restlessness isn't being helped by the benztropine. So again, is that really the culprit? Who knows? And finally, the lorazepam, she really states it's ineffective for this restlessness. So does she really need it? So tons of issues here, many opportunities on where to start. But moving on to the next slide.
If I may, Sydney, I'll just before you do, I think possibly the nurse practitioner in Cornell has joined us. I see someone there now that I figured out how to show the participants, and also the second year UBC pharmacy student, Jeffrey. I wonder if either of them would like to comment at all on how they would have approached this. If you do, try and turn on your video so we can see you if it works.
Hello. So I haven't learned a lot of these medications yet. So how I would approach it based on how a pharmacy student would is similar to what someone said in the chat. Most of these medications look like they're treating the symptoms, and then that medication has a side effect to it. So then we do another medication. So I feel like you need someone very specialized to try to strip down the medications, try to see what they are for. In terms of medications that popped out to me, I'm not really familiar with the benzotropine, but I believe that that might be the cause of something, but I'm not really sure. And in terms of what restlessness is, I think, as a pharmacy student, we would be asking more about, why are you getting restlessness? What really is restlessness towards you? I just feel like there's a lot of missing information in these cases, and that's how I, as a pharmacy student, would approach it.
Thank you. What about Rona Lohan? Are you there? Are you the person from Cornell?
Yeah, hello, I'm from Cornell, yes, nurse practitioner, urgent primary care. So I missed the first part of the case study, so I didn't really know what the question was, but I'm assuming, are you trying to remove medications? Is that the goal here, or? Yeah? Okay. How my approach with patients, if I saw a list like this, is just to go through them one by one together, see what their knowledge is, and ask them if they find it effective, right? So if like you said, the gabapentin seems to have a big benefit from it, then let's start working.
Excuse me, somebody's got a microphone that should be muted.
Oh, sorry.
I'm not sure if it could be you or not. Someone in the background there, but.
Oh, so I share an office with another provider who's super okay in the background, sorry. But anyway, so just, yeah, trying to find the one that maybe they're willing to let go of, and also, just checking side effects as well and seeing if, potentially one of the medications is restlessness, right? So.
Thank you. We'll move on to Sydney in a sec, but I just make one comment. I think we learned from Rochelle and Charles perhaps, and maybe others and Sydney that, well, I hadn't heard of what Sydney told us about what's known about gabapentin in children. I thought I knew a lot about gabapentin, but that was new for me. The idea that NSAIDs might cause some restlessness or odd sensations in the skin is new for me, but I think it emphasizes the fact that potentially all drugs that we take act in the brain, and certainly ones that we think of as analgesics. I'm not sure I buy the idea that they're really very anti-inflammatory or that inflammation has a lot to do with most pain. So I think of them as ketorolac or other NSAIDs as working in the brain. And if they work in the brain, then given that we know almost nothing about how the brain works when it's unadulterated, I don't think we should ever be surprised if somebody tells us, when I take this stuff, I feel this weird sensation. That's why argue with them. But personally, I would have looked at the Duloxetine because restlessness is a cardinal feature of dopamine blockade as akathisia. And some people will tend to think, oh yeah, but it's only 10 milligrams of Duloxetine. That's sort of like saying it's only a microgram of strychnine or botulinum toxin. What harm can it possibly do? It's the real issue is the drug giving some dopamine blockade that could be causing symptoms or not. And I agree with everyone else. We don't actually, and when it's this complex, we have no idea, and therefore you start somewhere. But almost anything here could be really messing with a person's brain. Okay, Sydney, back to you. I'll see if it'll move on now. Oops. There we go.
Sounds good. So because she determined she had very little benefit from the gabapentin, we figured we'd start there, have an easy win, and move on. So our plan was to decrease that gabapentin that was 600 at bedtime down to 300 for a couple of weeks, and then stop that. And then follow up a week later to see how she was doing and consider other medication reductions. But as what happens in real life, the patient decided to take her own path. So she dropped her gabapentin to 300 milligrams for just 2 nights, then completely stopped it. She described that restlessness is getting much worse, so much more jittery. So she restarted the gabapentin at 300 at bedtime. And when I was able to follow up with her again in a couple of weeks, she didn't want to make any further changes until after her next surgery, which was really quite unfortunate, despite us talking about all of the different possibilities and concerns. But I know she is going through the process of starting physiotherapy and acupuncture and things like that. So hoping to get some benefit there, but I would really, really like to see her off of many of these medications to see if we can get some of that cognition level back and get that restlessness under control, which then could in turn help the chronic pain. Any final thoughts on this case?
Just to comment, Sydney, Sharissa and I had a case where gabapentin was the only thing we could really identify as a precipitant was that gabapentin was stopped abruptly. And this patient ended up in the psych unit with all sorts of bad things happening to them. And I remember discussing this with Rochelle and with Tom. And I mean, you know, it's not necessarily described that it's a major problem, but then when you experience a case like this, you just, can we prove it? Probably not. But I mean, the way you tried to do it here is absolutely right. What do you gain by just stopping a thing when you can taper a thing and be more, and in this case, who knows, if she'd followed your taper, the result might have been different. And you know, the fact that she thought her restlessness increased after a few days, I mean, it could be related
Was that
to
from a gabapentin withdrawal? Who knows?
Well, it could, I think it could be, yeah. So we just don't know. But I've just learned, do not just stop gabapentin.
For sure. And then finally, just some thoughts on tramadol and Tramadol, that it is an opioid prodrug. And again, the metabolism is so variable person to person. And we like to think of, or some people like to think of it as a safer alternative to opioids, but that's really just not the case. And Health Canada has just recently announced that they're switching tramadol and related substances to the controlled drug formulary, and it will be required on duplicate prescriptions. So that's something to note going forward. It's not necessarily going to be an easier option. It's actually much more messy than if we went with a standard opioid. And I just wanted to shout out to one of Tom's colleagues at Therapeutics Initiative, Dr. Jessica Otti, and this is right now where you can stick in the information here, that she has a fabulous talk on tramadol on the Therapeutics Initiative website. So I'd encourage you to watch it. It's about half an hour, talks about all of the background to tramadol, the pharmacokinetics and dynamics behind it, as well as a lot of the side effect discussion and how we really don't find a lot of benefit from it, and it can actually be quite harmful. So I would encourage you to spend the time to watch that. And then it's over to you, Tom.
Okay, let's see if I can make this work again. Oops. Yeah, I just echo that. I've never prescribed tramadol myself. I think when we reviewed it in the Therapeutics Initiative in the early 2000s, it was very obvious it was a Me Too drug that had been licensed in Europe for, I think about 20 years. And it's considered quite problematic for addiction or opioid dependence in countries like Norway. It's a big issue, but for some reason, it was another thing you could market in North America and pretend that it was not an opioid. And technically that was fair enough. If you put it into slices of rat brain, it won't on its own bind to opioid receptors, but once it's passed through a liver, the active metabolite does bind to opioid receptors. So somehow it got by Health Canada into that special status that made it popular with primary care doctors and orthopedic surgeons, but there's certainly no advantage of it and a number of disadvantages, including costs. So here, this was an opportunity just to think, well, you know, if you are going to use opioids for people, I happen to be one of the rare people left who will admit that some patients really do better with opioids, and opioids seem to be safe. And I think it's a mistake to condemn them absolutely for non-cancer pain. It doesn't make sense to me that if I get myeloma, that I can have as much opioid as I want, but if I have horrendous degenerative back disease or hip problems and I'm not really fit to tolerate a hip replacement, that I can't have opioid because it's bad. That doesn't make any sense. But if you are, just point out a couple of things. We reviewed this in the Therapeutics Initiative and published this letter last year in which we concluded that there's no absolute way to be sure that it's safe to start opioids, as in a patient like one of the 18 of us, we're all good fellows and good friends and good girls, and there's no chance we'll ever develop problems of dependence and opioid use disorder. You just can't tell that. You can get some obvious warnings, including, I think Sydney mentioned to me that her patient has had a fairly troubled existence prior to the motor vehicle accident, which could be a warning. But the bottom line of that is just, you know, reserve them for when one has to use them, and then try to use the lowest possible dose for the shortest time. And on the other hand, up in the top left here, I'm just pointing out something where those of us who are registrants of the College of Physicians are are always supposed to read our emails, but very few do. But the deputy registrar in charge of opioid programs published a very interesting short note in January, February, in which he points out that we are all expected to be able to treat pain competently. And it's not okay with the College of Physicians to say, no, I don't ever use opioids, don't treat pain. So that there's an important implication of this, I think, for those of us who have had patients taking opioids long-term. I presume it would also apply to nurse practitioners, at least from the point of view of the College of Physicians, that you're not necessarily bad if you continue a prescription, which is a major change from 2016 or even 2019. And I think it could be, I certainly found it comforting. I'm close to retirement, but some of my patients who've done well with long-term opioid and have very good reasons not to use something else, for example, chronically bleeding peptic ulcer, which is life-threatening. There's no way anyone like that should ever have an NSAID. I think I can now write to the primary care providers, including nurse practitioners, saying, you know, this is no longer considered officially bad in a stable patient. So that's just, it's worth looking at if you want to find it. It's a little bit tricky at the College of Physicians website. It's public domain, but you have to look for the college connector, and then January, February 2001. So I thought another interesting experience I thought I would show you is, I would say I've committed some rather bad medical errors in my career that I wish I could have undone, but this was the longest running one. There are not very many errors that I committed year after year after year, and then eventually could say, oh my God, what have I done to you? Here's a woman who I inherited in 2006 from a prominent palliative care doctor who, in what you could call the golden age of OxyContin, was prescribing large amounts of opioids to almost anyone with non-cancer pain following a kind of cancer palliative care model. And when I met her, she was the doctor who had started this, changed fields, and sucked me into taking over the case, to put it bluntly. So she was on an enormous dose of morphine and a substantial dose of alprazolam, which is very high potency benzo, and venlafaxine. And my error was to think there's no way around this. I'll never get her down significantly. I did get her down under pressure from the college and evidence and guidelines down to 1,100 a day of morphine, but it was still enormous. And then in 2015, I thought, you know, she's 60 now, I should check her kidney function just in case there's a surprise. And as part of the routine kidney function tests that I've always done, I measured the plasma bicarbonate. Some Life Labs doesn't do bicarbonate as part of electrolytes, but Vancouver General does. And it was very high, and I realized, oh, I just proved that she's hypoventilating. I'm not allowed to expunge that from her medical record. If anything bad happens, it's sitting there like a red flag now, even though it's not mentioned in Canadian opioid guidelines, US guidelines, College of Physicians policy. I think I learned from this case, it's a very good idea to check the bicarbonate once in a while, or if you're doing electrolytes, pay attention to the bicarbonate. And I then made her do an oximetry overnight, and she was less than 80% most of the night. So that precipitated a change, and I'll show you next what happened. I told her we can't carry this on. I just remind everyone, I think the patients have consented in such a way that we can include the videos in the recording of this session, but remember their confidentiality should be respected just like any patient. So here's what she said by 2018 about her experience.
I have scoliosis. I've had chronic pain all of my life, but didn't know I had scoliosis until about 30 years ago. I began with opioids for pain reduction about 25 years ago.
You were told that it might end up causing problems, or whether it was sort of,
No.
this is a very good way to treat chronic pain?
That's right. I had just moved to Vancouver, and I was told that the opioids would work and that fentanyl would work. And so I was excited about taking them because I was in a lot of pain at the time and was unable to do anything physical, walking, sitting. I was in pain all the time. So I was eager. And I didn't know myself at the time the contraindications of those drugs. Otherwise, I might have made another decision. But I was on huge doses of morphine and fentanyl, and I also was taking Xanax. I was like that for 20 years. During that time, I was basically inactive, unmotivated, sleepy, lazy, in my mind and in my body. But I hurt still, and so I didn't consider reducing the drugs. I thought, in fact, I might need more, although it scared me. I began reducing my dose of morphine and getting off the Xanax, which I did.
So I didn't quite succeed in editing that the way I wanted, and the longer version is too long to show tonight, but I want to make some comments about it. But first, maybe I could just invite anyone who would like to comment to do so. What, if anything, would one take from what she said?
Tom, I will just say this is a tragedy, which I think you are saying as well. I mean, this is an articulate lady who makes really good sense. She speaks very well. And for 20 years, she was, at her own admission, zombie-like, tired in, I think she said, body and mind, or whatever she said. I mean, this is just really sad. This is the sort of thing that we see, but it's awfully sad.
So do you think I would have renewed the prescription for 9 years, from 2006 to 2015, if I thought she was zombie-like?
Yeah, but I think that we just all get into this. This is not any critique of anybody. I mean, I think what you've done to get her down to this dose that's an example of what can be done. And at least you got her there in the end, and she's making good sense now. And the key is that even at those massive doses, she was thinking she needed more. She'd somehow bought into this idea that this is helping her, even though her pain was still there. So there are a lot of lessons in this one, but I would, she's got a lot of life ahead of her, and she's down to 45 or 30 or whatever. So good on you.
I just wonder if I can invite anybody else, since we've got some guests who aren't always here in Quesnel, or Val Weber's up in Fort St. John, I think, or anyone else that has stir any thoughts in you, other than what a bad doctor I am or was?
This is Remy. So I took over a practice here when I came, and there are quite a number of patients on opioids. One of my biggest challenge, which I think you would have faced, is convincing this patient otherwise. It's a hill that is difficult to surmount. It's like, no, doctor, the pain is still there, but you explain everything to them. You ask them, what's your quality of life? And they'll tell you if they have more, the quality of life will improve. But you tell them, you have a lot and you're still sleeping. You're having a lot of side effects from it. So I think it's more of in the process of trying to do good, having some untoward effects that are negative on the patient. So I think one of the things I've learned, and I think this is buttressing, is that it's not always too good to jump on the new thing. You just have to sometimes be very cautious about it and step back and balance the negative effects and the outcome with what you are trying to achieve and see if actually you're achieving that. Because the whole idea, whoever started prescribing this medication, is give the patient a better quality of life. But the question is the patient getting it? And that's something we lose focus of once we start prescribing it.
Thank you very much. Dr. Okafor, you're in Tumbler Ridge or in Dawson Creek? Or?
I'm in Dawson Creek.
Dawson Creek. Anyone else want to say anything?
How is her pain currently with a reduced dose from her scoliosis? How is she functioning? Because I'm not sure, I've never seen a severe case of scoliosis where you cannot work, move, or do anything. Like, that didn't change probably that much, right? Must have progressed too for her. You know her story?
Yeah, good point. Well, she was originally offered surgery by one of the best spine surgeons at Vancouver General, and she declined it. And then I think years later when she went back, they weren't very keen on it. But one of the things I take from this is there were times in the waiting room when she would be asleep. And I called her on it and said, wait a minute, you're sound asleep out there. And she said, well, what if you had to wait for an hour and a half or 2 hours for your appointment? You'd be sleeping out here too. And in my case, she was right. I would have fallen asleep there. And I think there's an important lesson there, which is that most of the time in healthcare, we don't actually know anything about the patient. And it's particularly relevant because it relates to Sydney's case. How much do we know about a 22-year-old who was in a motor vehicle accident and has badly injured the fracture? You can try. Sydney can be very conscientious about trying to be open-minded and get to know her. But even if she works with her for a year or two, how much is she really going to know? And I can look back and realize I knew nothing about this person. I had no collateral information ever. And when she got cleaned up, she then said, oh yeah, I went to Mexico and my friends said, you're back, for 20 years you haven't been there. But she admits freely, every time I challenged her over a period of years, she said, no, I definitely need that. I couldn't possibly survive with less. So whether one sees her as in old terms addicted or nowadays opioid use disorder or just very tolerant and dependent with a legitimate kind of pain, part of the problem was not having any idea who she was. Believe me, I spent plenty of hours with her, at least an hour on every single visit, and I can look back and say I was an ignoramus. But I would say that that applies to so many of the other people that we treat, and particularly when we meet somebody who's already on drugs, we see them adulterated. And we can't possibly know what they're like unless we get them off of drugs affecting the brain. So that means essentially everyone in psychiatry. I think does anyone else want to say something further, or we'll carry on?
I just have a quick question. I don't know if you know the answer to this, but what is the perception of her pain now that she's on such a low dose compared to what it was when she's on high doses? Much less, I think. I mean, she went on and started doing more things. She, in a longer version that I might have shown, but it's a bit too long and I ran out of time to edit it. She took a lot of beautiful pictures in the West End of Vancouver, including flowers, buildings, interesting people on the street. So she's doing something with a camera. The pain is still there. It's just, her quality of life is better. And I've actually been able now to get rid of her finally to a general practitioner who's willing to prescribe 5 milligrams of morphine IR 3 times a day. And on the latest Pharmanet I looked at, she's getting some alprazolam, and I think she started citalopram or something. Okay, but she's better off. So I think what I learned from that is, be very suspicious always. Even if I'm not one of those people who would jump to say somebody is addicted, as opposed to
saying that they're tolerant and pharmacologically dependent. So, you know, what are we supposed to do then? I'm going to try to look at some other drugs now. We built in some didactic content, but there's no need to get through all of it. We can have as much discussion as anyone would like. And I can't see the chat, so Sydney or Raina can intervene if there's something that should be brought up from chat, or just speak up.
Christy's just made a good point that she feels like a lot of the difficulty of not knowing that what a patient's baseline is, especially if they're new to you, of what they were like before starting opioids. So to be able to establish the before and after, and to really see if there's an improvement or not, which is very true.
Yeah, and even, you know, people get drawn into the system, so relatives or family or spouse may or may not be as objective as one would like. It's kind of like the old diagnosis of Cushing syndrome, of excess cortisol. The best way to do it was to see a photograph of the person a couple of years ago when they look like anybody who's participating tonight. And then suddenly they're sitting in front of you looking like this with a moon face. You make the diagnosis because you ask, can I see a photograph of you at your wedding or whatever, whenever it was. So one thing to just remind us of, if probably the most prominent people now writing about pain in the world are at Oxford University, and I have some critique of them. I think they're a paper mill. They turn out systematic reviews that aren't necessarily very good, and they are rather conflicted. They have close relations with multiple drug companies, but they also have published a lot of common sense. And one of the most interesting ones is this paper published in British Medical Journal 8 years ago now, pointing out, well, the title says everything: expect analgesic failure from drugs, but pursue analgesic success. That no drug works well for more than a small minority of patients. Success should be defined not just as, yeah, I felt the pain's less, it's not as bad, which was the error with my patient with the opioid, but some kind of improved function. Ideally work for someone who's of working age and wants to work. And no one knows the best order to try drugs if you're going to try drugs. And they point out 8 years ago, you should judge success or failure within 2 to 4 weeks. I think it should be a lot sooner than that, and I'll show you why. But I'm going to review a few things that you can see from Cochrane reviews. Anyone can do this. Most of the abstracts are all available for free. Sometimes to get the full review, you have to go through a library, but full reviews can be more than 100 pages. So unless you're exceptionally scholarly, the abstract will tell you what you want. And amongst other things, from Cochrane.org, you can learn that with acetaminophen, there's high quality evidence, as the review authors put it, that there's no difference between a large dose and placebo in chronic pain. I don't know if that surprises anybody, but I think a few years ago, it still surprised me, and I stopped telling everyone, well, as a baseline, why don't you start by taking acetaminophen at least 3 grams a day? Once I started reading some of the modern clinical trials, I gave up on that. NSAID's the same thing, and I think this relates back to what we were discussing in Sydney's case. If one understood that in chronic pain, NSAIDs probably don't do much of anything, but have a significant potential to cause harm, why would we keep pushing them? Or why would we even keep prescribing them? Patient says, no, I can't live without my ketorolac or whatever they call it. Doesn't mean we have to renew it. And the same review found there's no evidence for any difference between one NSAID and another. So I think pharmacologically, if you're going to use it and you like a long-acting drug, then naproxen would be the drug of choice. And if you like a short-acting one, then it's probably ibuprofen. Here's an example where somebody violated all those rules. This is a young woman who has a strange anomaly that most of us have never seen or even heard of, called a Tarlov cyst, which is an expansion of the perineurium, which surrounds nerve roots as they exit the lumbar spine. And it actually, in this case, the cyst erodes bone. And for some reason, at around age 20, as she was moving a bed upstairs into her apartment, she changed from not having pain to having horrendous sciatica. And she ended up on all this junk at one point, which, when the drugs were all under patent still at that time, were costing her, a low-income woman, a single mother, $8,000 a year out of pocket. It was crazy. And she's an example of someone in whom opioid actually was fairly useful. And she's ended up at a stable dose of, I think, 135 milligrams per day. So a significant dose, but it makes her life tolerable. And the other drugs did nothing for her. Well, she knew this. She discovered that, I would say, 7 years before this was published, New England Journal of Medicine, a study from Australia showing, I've just got to change so I can see this myself. Over time, people with sciatica who typically will show up or get enrolled in a trial when their pain is bad, one doesn't go to the doctor when you're not being bothered by pain or to the nurse practitioner. They'll improve whether they're on placebo or pregabalin, and there's no difference. And it doesn't change over time. So this is a fairly unequivocal experience that shows that pregabalin is useless. For sciatica, there's a similar review published in New England Journal of Medicine. I think we're going to come to that in a minute. But here's something that very few people have paid attention to, which is evidence that when these drugs work for whatever people call pain, by which I imply that if you become sedated, for example, if you like to use alcohol and you've ever had the experience of feeling no pain, so to speak, it's not really analgesia, it's more being blotto that you're experiencing. But if you're in the 19th century and you have nothing else for an amputation or a dental abscess, feeling no pain from alcohol for many people is better than nothing. Well, in this case, when you give a large dose of gabapentin for acute shingles pain, within 2 hours, you can see a difference, or 2.5 hours from placebo. And at 3.5 hours, it's maximal, which is consistent with the absorption of the drug. So this would behave very much like an opioid or alcohol, or if you use marijuana, if you inhale marijuana, the effect is within minutes. This is determined by the absorption of the drug, and it might be a little bit faster. You can see in this case for acute pain with pregabalin, at 1.5 hours, you get pretty much the maximal separation of pregabalin in blue from placebo on some kind of a reduction in a pain scale. So I'm going to show you a little bit, just something to think about. Different experiences. This is a long-term patient of mine who has very difficult time with severe inflammatory arthritis and then osteonecrosis of bone from steroids and hip replacement, et cetera. And he's got some kind of peripheral neuropathy, which might be diabetic in his feet. See what you think of what he says about, this is not very good quality because it's just Zoom last weekend. But where did it go? Where's my
John, you've been using pregabalin for a number of years because of painful neuropathy in your feet. I'm wondering, what exactly does the pregabalin do for you?
Reduces the pain at night when you sleep.
How would you describe the difference between taking 25 milligrams or 50 milligrams compared with taking 150 milligrams?
The stronger the medication, the more I think it upsets my stomach. But the lower the medication doesn't seem to reduce the pain as much.
What made you reduce yourself from 150 down to as little as 25 milligrams?
Because of my stomach, probably, was the main thing.
And are you absolutely convinced that there's a difference between the smaller dose and the larger dose in terms of what you feel in your feet at night?
Correct.
By pain in your stomach, you really mean like the urge, you feel like you might need to throw up, or is it?
Yeah, correct. Sorry, yes. When you wake up in the morning. It will dissipate soon, but it's there when you first get up.
So I don't know if anyone would like to comment on that, but it puzzled me. He wanted a renewal of pregabalin, and he had been taking 150 milligrams, and I'd been hassling him about it for several years because of the potential that pregabalin added to methadone would cause a respiratory arrest. But all of a sudden he asked me, I need a renewal at 25. Why did he want to go down? I don't know if anyone would like to comment at this point. I think it took me a long time to elicit from him that it causes nausea, which bothers him the next morning. And yet he can clearly say there is some reduction in what's bothering him in the soles of his feet at night. In return for which he has loss of sensation, so it's potentially extremely dangerous for him to walk barefoot if he steps on a thumbtack or a glass or just gets his feet dirty. And I'm not keen on his having edema related to pregabalin or anything else in his feet, but he wanted it. Does anyone want to comment on that? I think it's an example of how, even when there are only a few drugs, how difficult it can be to figure out what is somebody actually experiencing.
Tom, at least he's taking it for a peripheral neuropathy, which is, what pregabalin is supposed to help. And I think what happens, your previous slides on sciatica, I mean, somehow we put it together. Okay, neuropathy, sciatica is a nerve root pain. Nerve is the common denominator there, and therefore it should work for sciatica as well. We just see that so often in our thinking as physicians, and there's a big difference between nerve root pain and peripheral neuropathy. And it's very gratifying to see your statistics there, your information on the ineffectiveness of these drugs for the sciatica. But I don't even want to think how many people are on these drugs for sciatica in BC without any effect, but with side effects. And it's one of the things that Charissa and I gravitate to very quickly in polypharmacy cases, because so many of these people are on pregabalin or gabapentin.
Well, here's another example of somebody who has a different reaction to it. One of the reasons, I'm not picking on pregabalin per se, that it's exactly the same things about gabapentin and many other drugs, but pregabalin and gabapentin, because they are also sedatives, they're also habituating. And in Britain, they're now classified as controlled drugs, and they probably will be in Canada before too long. But here's somebody else who had a different experience. So it's kind of funny. Look, he has, you'll notice the scar in his right neck. He was forced under the path of a semi-truck and nearly killed when the semi-truck ran right over his car. And Vancouver General saved him from amputation of his right upper limb and or death in the trauma service. But he sort of avulsed multiple nerve roots in the right neck. So he's got this large scar you can see in his neck from that.
We just found in there. Do you remember this stuff?
Oh yeah, this is awful stuff.
What was wrong with it?
It didn't do anything. All the doctors kept doing was increasing my dose over and over again until I can try to irk out some results. The only results I got were fatigue and weight gain.
Eke out or irk out?
Irk out.
You were irked?
It was nasty stuff. I recall coming into your office and you saying, "What kind of benefit do you get from it?" And I said, "I don't know." He said, "Why don't you stop taking it and see what happens?" So I stopped taking it, and the only thing that happened was I had more energy and felt better.
So for me, I I'm aware that withdrawal phenomena exist. They were reported for gabapentin in the late 1990s, not long after it was licensed, but I don't think it's terribly common. So I've personally chosen usually to advise people, feel free to stop either one. After all, they can always put it back. As long as you understand there's a possibility of withdrawal. It's like if you use alcohol, if you went into withdrawal from alcohol, most of us would go get some more, and because it's legal and it's easy to get. It took us a long time to learn that in hospital, and some hospitals, at least in Ontario, decided we may as well just provide alcohol to people who are going into withdrawal. It's the easiest way to treat it. One other way.
Tom, just before you move on, I just want to be mindful. We do have a few minutes left, so Tricia has put the survey in the chat box if you have some time.
Okay.
But Tom, depending on your time and everybody else's time, if we want to continue on, absolutely. But I want to be mindful of your time and dedication to this today.
I think we asked the audience at this point, do you want to carry on any further, or have you had enough for one day? It's
I'm enjoying this. It's very relevant.
There's at least two want to carry on.
Absolutely.
Right, we'll
those that have to go can leave, but we thank you for your time and just want to note that that's participation.
We won't be offended. I'll show you a few other things that might tickle your interest, or I'll try at least. So I just got to change this again so it's not obstructing what I can see. Here's another way. This comes from the same Oxford group, a different way of looking at how people respond. In this case, it's fibromyalgia and a huge dose of pregabalin. And the important, this can be very confusing to look at, but if we look at the weeks of therapy along the bottom here, and the percent of people getting an indicated response level. So very few people will get a greater than 70% reduction in pain using some kind of a scale, and very few will get a 50%. This nice green line is something more than a 0% reduction in pain. But what's more important to look at is when this happens. Supposing you're a person hoping to get a 50% reduction in pain. If it happens, it's by 2 or 3 weeks. And if you keep taking, if a group of people keep taking it, the percentage who get a meaningful reduction does not increase over time. I mistakenly put duloxetine. The same thing applies to duloxetine. In this case, it was pregabalin. If we then look at the same thing for duloxetine in fibromyalgia, it's very similar. The difference between duloxetine and placebo is maximal at 2 weeks, and it's pretty darn close to it at 1 week. And it may be that the dose was being, I've forgotten in this case, the dose may have been escalated between 0, 1 week, and 2 weeks. So once you get to the maximum dose, you see the maximum separation from placebo, which in this case is about 10% of people claiming to have a 50% or greater reduction in their pain, whatever that means. So the important lesson here is if drugs work for pain, it's basically right away, and you could follow up at either 1 or 2 weeks, or both. And it doesn't make sense to follow somebody up at 4 weeks or keep pushing the dose. You can say something from Cochrane reviews, very simple, about anti-epileptic drugs. Essentially, they don't work. Carbamazepine perhaps or probably works occasionally for true trigeminal neuralgia, but nothing else. So if in Sydney's case, if the Lamotrigine had been employed for pain, then it's a mistake. If it was used for mania, it's something still to think about, but might make more sense. And if you think about tricyclics, another major category, I've summarized this kind of in my own language. If you look at the Cochrane systematic review, which also comes from the Oxford Pain Group, they can't find any high quality evidence that tricyclics work for pain. So yes, but we all know from clinical experience they work. That is kind of a contradiction in terms, I think. Maybe they're describing either sedation or a placebo effect. There's, for tricyclics in general, there's no evidence for dose response, either for depression or for pain. And what we think of as small doses, we probably shouldn't think of as small doses, just as I made that point about the Duloxetine in the earlier case. Think of anything more likely as an extremely potent drug that may be affecting the brain in multiple ways. Cyclobenzaprine is similar. It's a tricyclic molecule also. And if you think of it as similar to amitriptyline or nortriptyline, you'll do well. And the adverse effects are very common. I think they're probably inevitable. That's a clinical opinion based on talking to patients and understanding, I think, how side effects, adverse effects are recorded in clinical trials. I don't think they're given very much attention. And if you talk to palliative care doctors, you would think that everyone who takes an opioid is always constipated because they pay a lot of attention to that. If you talk to psychiatrists, you won't realize the degree of anticholinergic effects because they don't pay attention to them in their patients. So it's really sedation, cognitive impairment. If it's happening after you take the drug, then it's happening around the clock because the tricyclics have very long elimination half-lives. Probably if you measured salivary flow or dental decay, you would find that everyone is affected. The alpha blockade that can cause postural hypotension and tachycardia and falls, it might be ubiquitous. It's not really tested most of the time. And the weight gain is probably ubiquitous. And then it will never be provable, but there are good reasons to be worried about as a very substantial increased risk of dementia if one takes any anticholinergic drug long-term. This is not something that can ever be proven because no one will do a long-term trial and it wouldn't be ethical to do it. So it comes from observational studies, but several observational studies have come to the same conclusion. And if you look at duloxetine, again, I've taken this from a Cochrane review. I suspect it's not actually true that the real results are significantly worse than this, but they'd say in painful diabetic neuropathy, about 1 out of 5 people would get a 50% pain reduction, whatever that means. And fibromyalgia or in depression with pain, much less. There's no dose response above 60 milligrams per day. That's clearly shown also in the product monograph. And if you look at the product monograph, you would say about 1 out of 6 people gets nausea, dry mouth, very common, constipation, anorexia. So it's probably acting also as an anticholinergic drug. So again, if you're going to use duloxetine, make a short trial and don't push the dose. And topiramate, I mention it just because one can't cover all drugs, but topiramate is one I think if you ever see somebody taking topiramate or attempted to prescribe it, think twice. Cochrane concluded there's no evidence it works in diabetic neuropathic pain or fibromyalgia. And in episodic migraine, which means less than 15 days per month, typically people with about 5 days of migraine per month, at 100 milligrams per day, it reduced by 1.2 per month versus placebo. So this raises a question, would you take a drug which has very major neurotoxicity if you could have 1 day, expect 1 day less per month with migraine? And we're not talking about the severe migraine people. We're certainly not talking about anyone who was ever given an opioid for migraine. I'm going to show you just an example of what you can find in a product monograph. For those who don't know, often if you're trying to learn about a drug, look at the monograph and look at the clinical trials. And you can find this in the topiramate monograph. It shows you it's about this difference between for example, in this study, 2 different studies, 114 people getting placebo, 120 getting topiramate 100 milligram per day, the difference in frequency of migraine would be approximately 1 per month. That's right there in the monograph. And 200 milligrams per day is not better than 100 milligrams per day. So if you know this, why would any neurologist tell patients start at a low dose and keep pushing the dose up towards 150 or 200? It's ridiculous. You can find that right in the monograph. I'm just going to show you how this plays out. I think we'll stop after this short video. How does it plays out in a person? This is someone, one of my long-term patients who developed a hereditary peripheral neuropathy, and he found codeine is, for some reason, codeine he preferred is a lot better than nothing to be able to sleep at night. But I decided I'm going to send him to the best peripheral neuropathy neurologist in BC, just in case she can think of something I haven't thought of, even though I know there isn't any trick. And this is what happened to him.
How long have you been working with your dad now?
It's about 3 months now.
What kind of work do you do?
With Garbage for the city of Richmond. I'm the swamper, he's the driver.
So he had been fine on that route?
Yeah, and no problems. We both know our run very well.
I was starting to find that doing a call, he used to go into the same place every day, and some of the places I would just completely block out 2 or 3 calls in a row. Wouldn't remember how to get to them or where to turn.
Simple things like next call in line, he wouldn't know how to get there. He wouldn't understand what needed to be done to get to that location. I had to reiterate and let him know how to get there.
Is he normally quite a good driver?
Yeah, really good driver.
And is that a difficult job, driving a large garbage truck?
I would say so. I don't think I could do it yet, but
it's class 3 license.
Did you know he was taking a new drug?
I was vaguely aware of it. I wasn't sure what the new drug was. It was just, I knew he was taking something.
Did you say anything to him?
No.
Even though your dad's a former bouncer, he raised you to be very polite.
Of course.
What did you think was going
on? Well, just I never really put 2 and 2 together, but you get used to doing the same route day in and day out. You forget what road to take or where you're supposed to go. And he would kind of gently remind me, oh yeah, Dad, you're supposed to turn there, or this is how you get there, or what road to take. And you kind of put it down as the stress of the day.
Who did put it together that there was something wrong?
I think we all kind of figured it out as a family. In the evening, when your brain starts to kind of relax, you start hallucinating on things. I would find, chasing imaginary hairs, like on my face or something. It felt like there was a hair on my nose or my cheek or something, and go to move your hand to do something or reach for something, and it was like your hand moving in slow motion with, 4 or 5 different hands moving after it.
Now, your wife sent me an email though, right?
Yeah, about we're having some problems, and I was starting to feel something wasn't right.
But she didn't make any connection to the new drug?
No.
Why not?
I don't know. We all didn't kind of put it together and figure it out.
What, if anything, do you recall being told about the drug and anything you should watch for?
There was nothing I was told about the drug, other than it would cause weight loss.
What about the pharmacist?
No, nothing from the pharmacist.
Were you given any written information about the drug?
Nothing that I can recall.
Did you look it up, or anyone in your family look it up on the internet?
My wife looked it up once we started having these problems.
After she emailed me, or before?
Yes, after she emailed you.
So how come nobody looked up the drug when you first got it?
We never thought of it. It's just one of those things that you trust what somebody's giving you is going to work. And
so even after all your experiences with me, you still trust doctors?
Yeah, absolutely.
Of course.
What's the name of the drug?
I don't know. Yeah.
How many were you taking?
I started off at 1 in the morning, 1 in the evening for the first week, and then I went 2 morning, evening. I was up to 3, and I was supposed to get up to 4 twice a day.
And do you think it did any good for the pain in your feet?
Pain in my feet, yes, it was doing good.
Yeah.
But yeah, the memory thing and the hallucinations is what was getting me.
I advised you by email to just stop it. How long did it take before you felt better?
Just over 24 hours before it started clearing out.
So yesterday you were driving safely?
Yes.
And did he make all the appropriate stops yesterday?
Yeah.
Yeah.
So I don't know if anyone wants to comment. I think that's a good place to stop because it brings us sort of back to where we started. Anyone like to make a comment before we close? I want to say one thing unless others beat me to the punch. I'm sure there's someone out there. What would you take from that guy's experience on the interview?
He says very impactful.
I mean, for me, go ahead.
Sorry. I just think that it was like a perfect storm that, you know, everyone assumes that everyone else is going to do the job of explaining the side effects of the medication. So the prescribing doctor maybe went over a couple things quickly on what to look out for, but then expected the pharmacist, you know, oh, they're going to be the dispensing, you know, person dispensing the medication. So they're going to be in more depth. They're going to give them the, you know, the handouts for the medication, and none of that kind of happened. You get that Swiss cheese effect where then all of a sudden the patient is left with getting this new medication and not really getting the proper education on it. So it's unfortunate, but I'm sure it happens all the time, and it's definitely a good lesson to take for me, for sure, with me.
Yeah, I find it hard to believe that he wouldn't have received an information handout, but I find it easy to believe that people don't read them, or if they look at it quickly, they absorb nothing. It's a next to useless way, particularly the longer it is, as opposed to saying, you know, on a small piece of paper like this drug may make you stupid. If you feel stupid or your family thinks there's something wrong with you, it's the drug. Stop it. That would probably have an impact. But I don't know the solution to this. It's just clearly not the way we alert most people now. And to me, the other thing is it reinforces the issue that we talked about with the woman taking the huge dose of opioids, or Sydney's patient. You know, how do you actually know anything about the person? Unless you're there with him in the garbage truck as his son, seeing the errors he's making, you don't perceive it. And even the fact that really the topiramate was stopped because his wife sent me an alarmed email, and she had my email and I saw it. He hasn't really absorbed that. And he's not stupid. He's just, he's not looking at it in the same way that some of us are, or he's impaired at the time. So I think we've covered as much or more than I thought I would get through, Sydney. So it's a good time.
I think just in your next slide, I think is just a great summary. And the point that really sticks out to me is just that reassess frequently. That exercise and fitness and physio, acupuncture, those types of things are so much better than any of the medications that we can offer. And the biggest thing is to set those expectations early on, that patients can't have the thought that this medication is going to eliminate their pain. It's pain reductions. And like you mentioned earlier, Tom, about, improvements in work and quality of life and things like that, not necessarily pain scores or eliminations of pain.
Yeah, I think there's still a big challenge, which I've never found the solution to. Incidentally, I added this at the last minute, but having shown it, it'll be available in the recording, or we can send these slides around if anyone wants them. If you actually wanted to know evidence about exercise for pain, the Agency for Healthcare Research and Quality has reviewed that last year in the US, and I find this kind of funny. There's low quality evidence supporting exercise, but they say in the bottom line, do it. If you want to understand the details, this is available freely online. And if you sign up for the US Agency for Healthcare Research and Quality, about every 3 or 4 months, they put out a similar huge review of something, which they're kind of handy to have, and you can look at them if you want. But I think we're left with the dilemma where if you told patients the truth about drugs for pain, you would undermine the placebo effect. Well, this probably isn't going to work, but you may want to try it. That's always been a dilemma for me. I don't like to lie to patients. And you wonder, in Portugal, people bit that one off and acted directly on it. They gave placebo or acetaminophen for low back pain, showed no difference, but allowed patients at the end of the experiment to have the placebo if they wanted to stay in that group. And some people asked to have placebo, even though it's labeled and known to be placebo. So since reading that experiment, I've been wondering more when I take acetaminophen or ibuprofen or naproxen, am I getting a placebo effect just because I believe in them? Any last questions or comments, or shall we go get our supper?
That was a great talk, Tom. Thank you, Tom.
Well, and Cindy says maybe she's going to tell us more about it in a few months if we have another webinar. So we both thank you for your attention and interest. Have a good weekend coming up. Good night.